Before we get into the really good stuff, which is what Heather's going to talk about, the case studies, I thought we could talk a little bit about how we data mine here at Cotiviti for hidden FWA and how you can take that information and bring it back to your plan. So if we move to the next slide, what I'd like to cover with you in these first 3 slides is, again, just a lens of how we identify potential FWA that may not be apparent through known schemes or coded algorithms that you use in your toolbox today. So, one of the benefits for us as an SIU within a payment integrity structure is that we get access to a lot of data. And that data gives us really great insights across payer information that we can use to bring to our fraud, waste, and abuse clients, but also just bring into our general investigative activities. So what I'm representing in the next 3 slides is a look at our prepayment claims editing solution that uses a collection of policies based on over 100 sources, including AMA, CMS, specialty services, state Medicaid guidelines, et cetera. So as you can see, and is pretty apparent from the graph here, is there's a wide range of scope across our policy collections that allows us to use an automated editing capability to edit claims on those sources I just mentioned. So as you look at this graph, it's probably not new news where a lot of the spend is coming from across certain specialties, especially as you look towards the left of the graph, the top of the graph here. There's a lot of coverage and editing. There's a lot of policy that we can code in these areas. And so it's sort of proportional to the spend as you look across these specialties. Where it gets interesting is where we're going to talk a little bit about today. We have several case studies, one of which is a dermatologist. So I wanted to point everybody to dermatology there on the right-hand side. It shows you that although the spend's very high, there's less editing opportunity there in the automated editing space, and it's easily addressed through comprehensive audits or manual review, which again we're going to touch on a little bit today with our case studies. As we move to the next slide, I have another view here to show you this at a CPT level and to kind of level set us to the content we're going to talk about today. So on the left-hand side, this graph here, you can see again kind of that proportional edit to payment ratio where, for example, not shockingly, 99214 rises to the top. This is typically top paid code, one of the top paid codes across payers, given the specialty span across those services. And it's also a place where we can edit pretty regularly and in a high volume. So it really makes sense that you'd see that line to bar merge there. And so when we looked at this, to pull out the codes we're going to talk about today, this graph would have probably been across, 10 pages. So you wouldn't see it in the view today. It wouldn't make a lot of sense. It'd be very small. So what we did was we took the same data and we just brought it over to the skin substitute codes that Heather's going to talk about today. And this shows you the difference in the volume that we would edit for these services versus what you might see for example, E&Ms. Very high dollar, but very low volume and less automated editing capability, just again, based on policy that we have available to code for. So we wanted to kind of give you that second lens to show you that when you look for these opportunities, they're very small in the grand scheme of things, but they're very large when you look at the magnitude of the problem that we're going to address today. As we move to my final slide, before I kick it over to Heather, and we have a fun activity planned in between, this again gives you another lens of how we look at the data. So for a 99213 and a 99214, the payment per line is relatively small. And so, that drives up the volume to get to that very large savings amount. Whereas for the Q codes, again, the codes we're going to talk about today, because I want to center us there, are very high dollar, but they're very low volume. So we wanted to show this to you to say, when you look at all that top spend area, the high volume area, you may miss something like this. in fraud, waste, and abuse is a hot topic. So we all know it's a problem. But when someone in payment integrity receives a report such as this, and where they're editing at a high volume and high savings ratio, this may fall to the bottom, which is why it falls to us. So we're going to talk through some case studies. We'll have some recommendations towards the end of the presentation. But in essence, my recommendation is you can replicate this at your plan. You may not have the cross-payer data that we have, but you certainly can get from your payment integrity partners this type of data that you could then kind of pull out some of the areas where maybe you haven't looked at in the past, or there's pockets of high-risk claims that are popping up. Take a look at those very high-cost, low-volume services, because at the end of the day, it's not being caught in an automated fashion, but it's something you can incorporate into your fraud, waste, and abuse toolbox or your intervention points that you have in place today. All right, so now for a little bit of fun. So for those of you that don't know me, I am a very big Harry Potter fan. So Heather and I picked out 2 questions along the way just to give us a little break in the content to talk a little bit about things that we love. So you'll see the poll pop up here. And the question is, which spell did Tonks use to fix Harry Potter's nose in Harry Potter and the Half-Blood Prince? So a couple fun facts as we start to collect the answers. In the movie, it was actually Luna who performed the spell on Harry Potter. So a little bit of difference between the book and the movie. And the first Harry Potter book, The Sorcerer's Stone, came out in 1997. The movie was released in 2001. So let's see, I think we've got enough results to publish at this point. Awesome. All right, so the answer is Episky. So about 32% of you answered this correctly. If you're not a Harry Potter fan, totally get it. This was one of those obscure spells that only came up a couple times, but great job, everybody. So before I kick it back over to Heather, again, thought I'd share some Harry Potter wisdom with you all. And funny anecdote, 2 keywords that my daughter knows and only knows about my job is fraud and prepay. And so that's all she thinks I talk about all day, every day. And so she would be very pleased to hear that I could talk about Harry Potter today. And I thought this quote was a great segue to talk about some pretty high profile fraud, waste, and abuse cases that Heather and team are investigating today, because it really is all about the choices you make along the way. And unfortunately, in this job, we tend to be a little bit cynical and we deal with a lot of bad actors. And so it's important that we're here to support the cause. So Heather, I will kick it to you to talk through some of our case studies.
Great, thank you, Erin. Hi, everyone. I am Heather Rickards. I'm a senior investigator at Cotiviti. Just to give you a little bit of background about myself, I am a certified fraud examiner. I'm an accredited healthcare fraud investigator through the NHCAA, and I've been working in the field of healthcare fraud, waste, and abuse for over 20 years. I'm very excited to be here today to share some of the cases that our Cotiviti SIU has been working on. And as Erin mentioned, Cotiviti has seen a significant increase in provider billing for the application of skin substitutes. Just to provide some background, skin substitutes are used for wound care, and they provide a barrier to support and protect wounds, and they aid in the healing process. The skin substitutes are used to stimulate tissue regeneration, and they replace damaged skin with functional tissue. Skin substitutes are most often being seen in the field of orthopedics, but they are also used by other specialists such as dermatologists, as Erin mentioned, surgeons, and also burn specialists. The cases that we'll be discussing today involve skin substitutes that are known as amniotic allografts. These are created from healthy human amniotic donor tissue, and this type of allograft is becoming more available as they have more donors, and it is being used a little more frequently as a skin substitute option. Okay, so let's take a look at our first case study, and this one involves a podiatrist who built a health plan for $2.3 million in skin substitutes for just 2 members in a 7-month period. So our Cotiviti SIU identified this provider through internal data mining, using the reports on our Cotiviti platform. The provider was found to be an extreme outlier among their peers for billing a single healthcare common procedure coding system, or HCPCS code. In this case, it was Q4173 for the Palingen allograft, which is a brand name allograft. And of note, skin substitutes are typically billed as 1 unit per square centimeter. In this case, records were requested from the provider, and the medical record resulted in a 100% error rate, and that was upheld upon appeal. The provider didn't agree with the audit findings, and they requested a discussion with Cotiviti and with the health plan. The provider was also very specific about the meeting time for this meeting because of their office hours and their schedule. So when they joined the meeting, it was very unusual that no one from the provider side joined the call. So it was later learned that the provider and their medical partner had been criminally indicted for a Medicare fraud scheme that involved nearly $100 million, and it was mostly attributed to skin substitutes. So what we can talk about too is what the Cotiviti audit and the federal indictment found. So some of the findings included patients who received skin substitutes that did not have qualifying wounds. This means that they may have had minor skin irritations or they had no wounds at all. Some of the medical records were falsified to indicate that the patient had a wound that was improving with each visit. Some of the patients were also informed falsely that the skin substitutes would do things like boost energy and just overall repair tissue damage, just to obtain their consent to apply the skin substitute. And also the providers, knowing that law enforcement may interview patients, they had some of the members complete a short form falsely stating that they did have wounds that would qualify for a skin substitute, and these statements were even notarized. The providers then diverted those fraudulently obtained funds into cryptocurrency, expensive jewelry, vehicles, and private jet travel. So they had quite a fun time. So at this time, the client has suspended all payments to the provider, and this criminal case is ongoing. Okay, so let's take a look at another case study. This one involves a vascular surgeon, and this case is currently under investigation by law enforcement. This provider was found to be an outlier by the Cotiviti SIU through internal data mining, and they were found to be an outlier for HCPCS code Q4262. Again, this is also an amniotic allograft. In this case, it was very difficult for us to obtain the medical records. We made multiple requests, and the provider stated they still maintain paper records, and all of their records had been moved off-site due to a flood. We did eventually receive the records, and the audit resulted in a 100% error rate, which was upheld upon appeal. The records were found to be lacking information, such as the size of the wound being treated, also the patient's underlying medical condition. The photo of the wound that was embedded in the report was blurry, so therefore any numbers that may have been in the photo, such as measurements, could not be read. The identified overpayment in that case was $104,000. And again, that was only for 2 members, and that was paid out over a 2-month period. This case, again, is currently under investigation by law enforcement. The next case study involves a podiatrist who billed in excess of $180,000 for skin substitutes, and this was just for a single member. The provider in this case billed 3 different allografts under HCPCS codes Q4204, Q4250, and Q4248. Internal data mining by our Cotiviti SIU not only revealed that this provider was an extreme outlier among their peers, but also revealed that over 99% of the provider's revenue was generated just from the application of skin substitutes. Medical review resulted in a 100% error rate, which again was upheld upon appeal, and this resulted in a $183,000 overpayment. In this case, the health plan is currently working with the provider on a settlement. Okay, and so another area where the use of skin substitutes is becoming more common is dermatology. The Cotiviti SIU identified a dermatologist billing HCPCS code Q4234, and that's for the accelerate amniotic membrane. This provider experienced a large payment spike, which is another common trend that we're seeing and a good way to identify some of the providers. And this was identified by the Cotiviti SIU utilizing our fraud, waste, and abuse detection reports. The provider submitted medical records, and again, these were found to be blurry and very difficult to read. In this case, the overpayment identified was in the amount of $203,000. The provider in this case opted to pay the overpayment in full after just receiving the initial findings, and they did not submit an appeal. So finally, the last case that I'd like to review involves HCPCS code Q4205, and that is for the BioLab membrane wrap, and also Q4281 for the Barrera dual layer amniotic membrane. For this case, the provider, who was also a podiatrist, submitted records that did not include the location of the patient's wounds or where the allograft was placed. There were also no images of the wounds included, so there was really no way to confirm that the actual skin substitute was applied to the patient. In this case, there was nearly $90,000 identified as overpaid. And again, this was only for a single member, and it was paid out over a 2-month period. In this case, the provider has not responded to our multiple attempts at outreach, and we are working on next steps to resolve this. Okay, so now that we've discussed several case studies involving skin substitutes, let's talk about some of the key takeaways. The skin substitutes definitely come with a very high cost. 1 unit is equal to 1 square centimeter when they're billing skin substitutes, and they can range anywhere from $700 to close to $2,000 per unit. And skin substitutes also require multiple applications to effectively replace or repair the damaged tissue. So therefore, you will see multiple procedures per member. So this is why you won't see maybe a high rate of members being treated, but you will see a very high cost attributed to a low number of members. As skin substitutes, such as the amniotic allografts, are becoming more available, we are seeing that more providers are offering them as an alternative to other skin substitutes. Providers that are new to billing skin substitutes may also experience large spikes in payment due to the high costs and the multiple applications that are required. Skin substitutes are, again, they are commonly seen in orthopedics. We are seeing it a lot with podiatry, but we are seeing them in other specialties, as we mentioned. Surgeons, dermatology is another area where these are popping up. And also, these are, again, post-pay reviews that I reviewed, but we are seeing health plans requesting prepayment reviews for skin substitutes. And we do have one health plan that alone has $3.7 million currently in prepay savings that is attributed to skin substitutes. Okay, so I know that was a lot of information, and so let's just take a little bit of a break. So I think next up we have a poll. So I am a huge Seinfeld fan, so I'm not sure. So those of you who have not watched Seinfeld, it's definitely a good binge. So we do have a question from the show Seinfeld, and it is: what iconic item from the popular 90s sitcom was donated to the Smithsonian? So if you're not a fan of Seinfeld, this could also be a good trivia question if you're out at trivia night or something. So little known facts about the show: was known as the show about nothing. Jerry Seinfeld was actually one of the first TV actors to earn $1 million per episode. So I found that very interesting as well. And so I'm not sure, again, how many people are. I know it's an older show from the 90s. So, and there was actually an episode where the actor who played George was not in one of the episodes, and he actually threatened to leave the show. So that was interesting. And Larry David, who was the creator, he also did not want the characters to socialize outside of the show. So they really were just coworkers who did not socialize outside of the show. And we also have, let's see what other little known facts we have. So also the creator of Seinfeld is the writer and creator of the show Curb Your Enthusiasm. And if you are a Seinfeld fan, they did a reunion on season 7 of Curb Your Enthusiasm. So that's another interesting fact about the show. So we have, so hopefully we have enough people answering our trivia question, and it looks like you guys got it correct. It's Sherry's puffy shirt. All right, great job, everybody. So now that we've had this fun activity, I'm going to hand things back over to Aaron. Oh, we have Dr. Van Nostrand. I did want to talk about him a little bit. So one of the characters, Kramer, on the show played a doctor. So if we were to audit him at Cotiviti, we might see some interesting things in his medical records. So just to give you a bit of an overview, Dr. Van Nostrand, things that we might audit him for. So just a little fun activity. I hope you enjoyed it. And I'm going to hand things back over to Aaron.
All right. Thanks, Heather. So now you've gotten to know what Heather and I enjoy outside of work. Now I'll tell you a little bit about what I enjoy most about working with all of you. So if we move to the next slide, what I'd like to share with all of you is just kind of a sense of where we see our partners succeeding and how they're making a difference in how they're intervening with provider behaviors. So what I'm representing on this slide is a depiction of post-payment and prepayment results. So remember, I said my daughter thinks I only say fraud and prepay all day long, but now I can add postpay to the list. So she's not listening today, so I'll have to use you all as witnesses next time we have this conversation about what I do for work. But on postpay, as all of us are very aware, the return on investment is relatively low. And so obviously having multiple interventions, multiple tools in your toolbox, it increases your results. But it's not to say that we're not making a dent in some of these investigative activities. As Heather mentioned before, we've got some really good cases in just this specific area, but we alone as an SIU support many different clients across the country and work through hundreds of cases per year to address a lot of these concerns. And so looking at postpay, the recovery rate is anywhere, what I've seen is between 20 and 50% of what you're identifying up front. And so we thought we'd give you a sense of what that translates to in terms of dollars per member, and then the average number of cases that are actually resolved in years. So this isn't meant to say 56 is the average for all investigative activity for the year. This is just what's resolved within a 12-month period. The recovery percent is about 0.18%. And so relatively low in terms of if you look at just general professional spend, for example. Settlements often take a very long time. It is a substantial lift to investigate cases post-payment. And so we work with our partners, and many of our partners that use other vendors as well use prepayment as a supplement. And I think this helps bolster results for sure, and gives you a better sense of how you can capture the information up front and deny the claims before trying to chase them years and years down the road. One of the cool things about what I showed you in the beginning of the presentation is just a way, again, for you to figure out which providers to target, because prepay can be a bit abrasive if it's not done correctly. So targeting and making sure you're really addressing the egregious outliers like we've talked about in these case studies today is really important. And then obviously considering all the different interventions you have at your health plan beyond fraud, waste, and abuse. Prior auth is an example. I'm seeing some questions around that, so we'll get to all your awesome questions. Considering, the provider network, and again, abrasion are all concerns that you want to consider as you take an approach that uses multiple interventions. But for us, if you look at the difference between postpayment and prepayment, obviously the results on prepayment are substantially higher than they are in postpayment. And this is obviously just because we're denying claims up front instead of chasing the dollars after the fact. So what this does for you is really, in essence, enable faster detection. So if you take any sort of fraud, waste, and abuse prepayment intervention, couple it with payment integrity data, I think you have a really good recipe for success. All right, let's move to the next slide and talk a little bit about what we anticipate seeing for 2026. I don't know how much all of you have been following as the physicians' fee schedules, et cetera, are being arranged for 2026, and some regulatory changes in response to some of the growth we're seeing in this specific area. One of the things on the table is obviously putting caps on payments for skin substitutes. So if you look at the magnitude of the issue we talked about today, and the growth of the spend just in skin substitute, it's very substantial. And so there's some proposals to change the payment structure for these services and also potentially put a cap on payment and reimbursement for skin substitutes. So something to look out for in the coming year. It's not finalized yet. And obviously, as we're seeing more about fraud, waste, and abuse efforts in the news and the focus on Medicaid fraud prevention, it's really important to think about how this will impact your work and how you can make more of an impact in some of these low volume, high cost areas. So more to come as we get to the end of the year. If we move to the next slide, we like to leave you with an action plan. So peppered through the presentation, we've talked a little bit about some of the things you can do up front to find these things before they build up and result in millions of dollars of losses. But this is sort of an immediate plan that we think is pretty actionable. And it's pretty flexible just based on what you have at your disposal at your plan. So it doesn't require you to partner with someone like us and have that sort of vast data set. Certainly helps, and we're always willing to answer questions that you have and partner with you in that way. But these are some things you can just bring back to your desk to data mine and really think about skin substitutes and just general high spend areas. So as I've mentioned a couple times so far, one of the things that you can do is start looking at your high cost, low volume services. So it may be something that, you've got some low flyers that you need to address that aren't being addressed upstream in payment integrity or even within your fraud, waste, and abuse unit because you don't have analytics that specifically look in these areas, given you've got so many other areas that you've got to focus on. From there, obviously, then you can take it down to that provider level and analyze the individual provider billing to see which providers are rising to the top and which ones you can intervene with pretty quickly. And then from there, just create your investigative plan to maximize your tools and technology. So you may have a fraud, waste, and abuse platform that you use. You may have some homegrown applications that are providing significant value. And obviously your SIU investigators who are at the front lines and looking at the data every day. So catering it to what you have at your disposal is important, obviously. So that's for Monday. That's your homework. For the next 90 days, just think about more proactive identification. So I'm not going to go down the AI train. We've talked a lot about it within our sessions and across the board in the industry. Certainly AI is something to consider in terms of creating efficiency for yourself, but also creating models that allow you to look at some of the information that we looked at today, because it really isn't relying on some of that egregious outlier behaviors. It's looking for anomalies. FWA tools. So you all probably have various vendors you work with, thinking about how you can partner with your vendors to create specialized rules or just do some general analysis for you on anomaly detection if it's not already something at your fingertips. So some things to consider and to brainstorm to get ahead of these things. We talked about post and prepay. We've talked about it a lot over the years. Having multiple intervention points obviously helps. Not only does it create an environment where you can create an environment where it's more compliant and a provider will respond to you more quickly because it's your withholding payment, but it's also a way for you to, again, reduce losses. And then within the next 90 to 365 days, we talked a little about, some changes that are ahead for 2026. It's already August, so I'm sure everybody's starting to plan and budget for next year. So think about your regulatory and policy changes that may be ahead of you. And then just investigate ways to be proactive against anticipated risks. So investing in all your fraud investigators who are here today, getting their AFI credits, investing in technology where you need it so you can do these types of analyses. And then obviously collaborating with the 900 plus people that are on the phone today. We've got NHCAA coming up in November, shameless plug. Heather and I will be there. Maybe we'll have some more fun trivia questions. So feel free to stop by and see us. And then just candidly, if you have questions that you haven't addressed in this webinar, we're always here to help. We may not be your vendor for fraud, but we certainly would love to be your partner and answer any questions you have along the way. So put that in your plan to reach out and ask questions if you have them. And from there, I think I'm going to turn it over to Beth to start some Q&A because we've got a lot of questions to answer.
Think about Harry Potter and Seinfeld at work. So for that, I thank you. And I bet a bunch of our audience members do too. But seriously, thank you so much for your great insights today. And that little homework plan you gave us gives us some really actionable, concrete steps to improve SIU programs. Listeners, I hope you found that helpful. I'm sorry. I hope all the listeners found that helpful. We'd love to hear from you about your action plans and how we can help fulfill your needs. We're now going to begin answering the questions submitted during today's presentation. And as a reminder, you can still submit those questions through the Q&A button. Erin, actually, I think Heather, our first question could be for you. Erin might jump in on this, but what are some other trends you're seeing in SIU?
Sorry, that question's for me. I apologize.
No worries.
Sorry about that. Yes. So some other trends that we are seeing in SIU, we're seeing a lot of behavioral health, which I know a lot of health plans are also seeing. Labs still, a lot of urine drug screens are still an ongoing problem. Home health, genetic testing, and more recently, I think I've been seeing a lot of an increase in DME more recently has been on the rise. And also on the dental side, we've been seeing some excessive dental restorations like fillings and crowns. So a lot of those things are definitely still issues for us.
Awesome. Thank you, Heather. A few more coming in here. Heather, I think this is you also. Do you see the spend continuing to trend up for skin substitutes?
So yes, so the short answer is yes. So right now, so since, we are talking about some provisions that CMS wants to put in place. So I would say that before that can take place, we know that there are bad actors out there. So they are going to want to, bill as much as they can now before that goes into place. So I would say that yes, we will see definitely a trend up before any of that takes place. So it is definitely something to be on the lookout for now, for sure.
Okay, well, so many going on in, so appreciate your patience as I page through these. Erin, I think this is for you. Have you heard of providers charting that they packed the wound with the excess instead of wasting it?
Yes, so I saw that question come in earlier and I did not have the answer. So I was able to actually ping one of our medical review managers who said yes. But his concerns were obviously, if you're packing the top of the substance, how is this benefiting the healing as it's not in contact with the skin? So it would call to question whether or not it's medically necessary. He also provided some insight on providers billing 3 times the amount of the skin substitute larger than the wound, and they note that they used all of it. And so again, did they use it on another patient, or what did they do with it? So certainly a lot there in terms of record review and findings that we could probably share. So certainly if there's follow-up and there's other questions that we could address in this time together, we're happy to do so.
Thank you, Erin. This is for Heather, I believe. Heather, is there a medical reason that a provider would use an amniotic allograft over something that might be a less expensive option?
So an amniotic allograft, the provider might choose to use that over something other than, say, a synthetic skin substitute. So there are other types. The amniotic allograft is just one type of skin substitute. So there are others, again, that are synthetic. They have skin substitutes that are derived from animal tissue. But the amniotic allograft, since it is derived from human amniotic tissue, can have less complications for the patient. And there's also something called an autograft, which is derived from the patient's own skin. So that requires a little more. So they would have a surgical site in addition to the wound that they already have. So the amniotic allograft, it's something they're kind of moving away from autografts, because obviously that is a little more risky for the patient. So they are moving more towards the amniotic allograft. So, and that of course is if the patient has a true medical need, they may opt to use the amniotic allograft.
Awesome, thank you. I just want to read a comment here. This is not a question, but Brad wanted to let us know that they've seen wound care products being submitted for $4,000 to $5,000 per square centimeter. Thank you for that, Brad. That's really interesting. Wow. Okay, let me find what's next here. Sorry. Okay, I think this is for Heather, but Erin, you jump in if this is yours. And this is, are you seeing claims with modifier 76 on the Q codes?
I'm not familiar. That's not one that I've seen recently. So I don't know if Erin might have some background on that modifier.
Not specifically, no. We could certainly take that back to the larger team and see if they see that as a trend and follow up with an email if that works. But I
can say the modifier was not an issue with the case studies that that we've had and some of the recent cases.
Alrighty. ABA, Applied Behavior Analysis Therapy. Have we noticed a spike in payments? I know we've talked about this recently.
Yes. So certainly for both pre and post pay investigative activities, this has been a focus. Obviously, given it's a sensitive specialty to address, we handle these cases with care, but we certainly have had quite a number of unfortunate bad actors in this space that we've had to address with our clients. It's something that we haven't really seen trickle down. It's just continues to stay pretty steady across our clients. So it's something that most of our clients want to keep focusing on, knowing that there's high FWA in the space.
Thank you, Erin. Here's another. Have you seen any upticks in Q4159 billing for podiatrists?
Heather, do you have a thought there?
That's one that I would really have to look at our data to answer that question. I wouldn't really be able to answer that off the cuff. Yeah, that's something I would have to look into further. But if we are, if that's something we can follow up on, I'd be happy to do that.
Yeah.
Okay, Heather, I think you're going to jump all over this one. Would a high number of members receiving skin substitutes, but only for 1 or 2 procedures, be cause for concern as well?
Yeah, I would say if you had a high number of members receiving skin substitutes, definitely. Unless it's a specialty. I mean, I would think it would have to be very specialized. I mean, if it was a burn unit where, maybe people were being treated for severe burns, it would have to be a very, very, very specific type of provider that would only treat for serious wounds if you were seeing a high number of members, because typically these are serious wounds that won't heal. Typically, if you're a healthy person and you have minor irritations or minor wounds, they typically will heal on their own. And these are really more for, people maybe who have diabetes and they have wounds that will not heal on their own. So there typically wouldn't be, a high population of people that would require skin substitutes. It's not, everyone that would need them. So I would think that would be unusual unless, again, it was a provider who is dealing with a specialty area such as severe burns or other types of wounds.
Thank you for that. Appreciate it. Okay, see, we answered that one. Can a nurse practitioner bill for the skin graft services? Do you know that, Heather?
That's a question I'd have to look into, but I can definitely follow up on that one.
Okay, great. Here is a question. Would the only 2 visits be a red flag?
Two visits, yeah. Typically, the skin substitutes do require multiple applications, so 2 visits would be low. Typically, 1 or 2 applications it may not take, so they would have multiple appointments and multiple dates of service. So I think 2 would be on the low end.
Yeah, we have a couple people asking about DME practices here. Heather, do you want to, or Erin, do you want to speak to anything we've seen in durable medical equipment?
Oh, man, what haven't we seen in DME, unfortunately? It's sort of one of those areas that is always a forerunner on fraud investigations. I recall a couple weeks ago, we were having discussion around drop shipping and submitting Amazon receipts for a case we were working on from a DME supplier. And so there was some noise there. But DME is always an issue. I feel like it's very cyclical. And so some of the things we looked at 10 years ago are coming back around, but it's always something we should be looking at.
Yep, and we've done 2 blogs recently about 2 different DME schemes. So I would encourage you to go to cotiviti.com/blog and check those out. Those were pretty interesting. You can read some case studies that we did on those. All right, Erin, see any other, I think we're getting about to the end of the questions here.
I see a couple that are interesting that if you don't mind me jumping in, Beth, because there's so many. We're trying to get to all of them. I'm sorry, everybody.
I apologize for the pauses. It's difficult. Yeah.
Yeah. I'm a little upset there's no Harry Potter questions. Just joking. All right, let's get back to this. All right, so any upswing on phantom providers? So interesting topic. I wouldn't necessarily call it an upswing, but a problem that's never really gone away. So just kind of to provide some insight on how we look at phantom providers. We have some analytics that look at like new entrants into our plans network to kind of get ahead of the billing. So, you know, if you think about phantom providers, there's usually some sort of like test claims that hit the system and then a dump and then they're gone, right? So, I mean, if they're smart. So when we think about this and AI, that's where it gets a little scary. I've said AI twice. Sorry, I said I wasn't going to, but that's where it gets a little scary because, you know, back 15 years ago, when you're thinking about identity theft and you know the different technologies that were at providers' disposal before, they've become more sophisticated. So if you've seen any of the recent webinars through NHCAA that highlighted AI, and we're talking about very sophisticated calls to get members' information and all kinds of different methods they can use to fabricate records and make it look legit. So certainly something to keep watching for and do some data mining up front around any new out-of-network potential MPIs that may start testing claims and submitting low volume, and then you may see a spike. So that's just some recommendations there. There was another one about AI. There's 3, sorry. With the evolving use of AI in medical fraud, what practices do you use to detect? Oh, it disappeared because we got another question. Where'd it go? Something about medical records, I think it was. To detect modified medical images and records. So we do at Cotiviti use AI to combat AI. So we use it as a enabler to recommend potential investigative work to our resources. So it's something that you can use to kind of look at patterns of behavior. If you think about just general cloning, you can start to see some patterns over time where you would pick out where it might be AI generated. Or looking for sort of like just general inconsistencies around the wording and it kind of not making a ton of sense. So those are some things to consider there as well if you don't have an AI tool that you can use to look for those types of trends.
Erin, I think I see a good one for Heather.
Okay.
Should invoices for skin substitute products be requested when requesting medical records?
So it's always a good idea to see, I mean, just like with DME items, it's always good to see what the provider paid for the item that they're billing the health plan for. It's always important too to see, again, like we mentioned before, how much of the skin substitute was used, if there was any waste attributed, and if that should be noted in the record that it was all used, or if there was any waste, the size, everything like that. So that is always a good piece of information to have to make sure that there is no upcharge or anything like that is occurring. So that's definitely a good idea if you do suspect that they are overcharging for that skin substitute.
Thank you, Heather. I think that's about everything that we have time for today. There were a couple that we might follow up personally because they were very specific, but we really appreciate your interest in all of your questions. Few notes to wrap up here. Thank you again to our speakers, Erin and Heather, for making it so clear what great payment integrity data, deep expertise, and a multi-pronged approach can do to improve SIU programs. Thank you, all of you. I've been watching the attendee list and everybody's been hanging out the whole time. Great attention. That makes it really delightful for us to present to you when we know you're so involved and interested. We will be reaching out to you via email shortly with a link to the on-demand webinar recording and information about your credits. So don't forget to take a moment and answer our survey about your experience today. We do read those surveys. We listen to them. They're very important for us. Any closing words from Erin or Heather today about Harry Potter or you know, fraudulent abuse.
Don't open the window because I will do it. No, thank you for your time. We really enjoyed putting the content together. We always enjoy sharing insights with you. So the door's open, certainly, if you'd like to have a conversation with Heather and I. There were quite a few questions we didn't get to. So we'll try to answer those via email for you. And the ones we just didn't have information on, we'll certainly circle back. But feel free to reach out to us at any time. We're all in this together, and we appreciate your time today as we talk through some insights. But Heather, did you want to close us out with anything Seinfeld related?
Great. I just wanted to say thank you to everyone. Thank you for having us today. And like Erin mentioned, please stop by and see us at the annual conference if you are there. And I think that's about it. So thank you again for joining. I've really enjoyed discussing our Cotiviti cases with all of you.
Thanks a lot again. It's really such a pleasure to work with people who love their jobs like Erin and Heather, and all of you today who obviously have such a passion for this very important work. So again, we appreciate your time today, and we look forward to seeing you again soon.